Okay, so if you remember, yesterday's topic was about the stimulants. So today would be about the blocking drugs. And the main one that I'm going to talk about would be the muscarinic blocking agents, but not the nicotinic blocking agents. So the nicotinic blocking agents, you will learn that in muscle relaxant lecture. Okay. All right. So I'll talk about this plant later. All right. So these are some of these are the objectives of today's lecture. So you will be able to classify and state the prototype or examples of the cholinergic blocking agents, which include the nicotinic blocking agents such as tuberculin, and you will learn this again in muscle relaxant lecture, as well as the muscarinic blocking agents, which is the atropine. So this would be the focus of my lecture today. And then, of course, you have to classify the muscarinic blockers according to their effects on various receptor subtypes, and then the prototype for each of the muscarinic blockers. And this includes all this lah. So we have atropine. So as atropine, scopolamine, ipratropium, benztropine, and tropicamide. Okay, and then need to discuss the mechanism of action, what are the clinical uses, what are the relevant pharmacokinetics, any specific organ system effects, as well as the adverse drug reactions of both topical and systemic administration of atropine. As well as you will need to be able to describe the signs and symptoms of atropine poisoning or any drug that contain anticholinergic properties and what are their treatments. Okay. All right. So if you remember yesterday, autonomic nervous system, it's a balance between sympathetic and parasympathetic nervous system. So we're not going to this one, no need to think about it at all now, although there's a balance between parasympathetic and sympathetic nervous system in your autonomic nervous system anyway. So we want to focus more on the rest and digest. All right, so what is blockade? So blockade is, if you remember from your GM2 in pharmacodynamics, blockade is basically antagonist or antagonistic effect. So you go, a certain ligand go and bind and does not produce any effect at the receptor. Okay. So we basically we go back to what antagonism means lah. Okay. So cholinergic blockades just means that the agent bind to the cholinergic receptor and prevent acetylcholine from binding and also activating the receptor. So semalam we look at the stimulant, so it binds and activates the cholinergic receptor. So today it binds but does not cause any activation and also prevent the binding of the agonist, which is the acetylcholine. Okay, so if we look into cholinergic antagonists, of course, because there's two types of receptors. So one is nicotinic receptor and the other one is muscarinic receptor. So obviously there will be two types of antagonistic action on the cholinergic receptors. So one would be the nicotinic antagonist. So this one would basically be binding specifically to the nicotinic receptors and modulate the opening of the ligand-gated ion channels. So what it does in a nutshell, because if you remember yesterday when I talked about nicotinic receptors, when acetylcholine bind to nicotinic receptors, the channel will open kan? Okay, so the channel will open, sodium will go in, and that will change that will cause depolarization. So in the essence of nicotinic antagonist, so it blocks and it prevents the opening of the channel, and that's basically it lah. So one of the example would be the tuberculin, which is a muscle relaxant. And then the muscarinic antagonist. So this would be cholinergic antagonist that binds more specifically to muscarinic receptors and prevent the activation of the GPCR ni because muscarinic receptors are GPCR kan, and then prevents the activation of this GPCR by acetylcholine. So one of the agent that is we are going to talk about today would be the atropine. Okay, so just to recap on both nicotinic and muscarinic receptors. So if you remember yesterday when I talked about nicotinic receptors, there are 5 different what do you call that, subtypes yang that build the whole of the nicotinic receptor. Okay, so this is the nicotinic receptors, and then of course this would be the muscarinic receptors. Okay. And muscarinic receptors, because it is a G protein coupled receptor, so it always will have this G protein, so the alpha, beta, and gamma subunit. Okay, so if you remember yesterday that I've shown this picture yesterday as well. So when you have a muscarinic agonist, so it binds to, if you remember again, M1, M3, and M5 are GQ proteins. And M2 and M4 are GI proteins. So if you stimulate M1, M3, M5, that would lead to increase in phospholipase C, or activates the phospholipase C, leading to production of IP3 and DAG. And this is, we call it excitatory lah, because it's GQ, and then it increases the phospholipase C enzyme. Whereas the inhibitory muscarinic receptor M2 and M4, when you activate them, this would cause the adenylyl cyclase to be inhibited. So when you inhibit adenylyl cyclase, that means your cyclic AMP will be produced, so it will go down, and this is what we call inhibitory. So kita terbalikkan benda tu when we have muscarinic antagonist that we're going to have today. So when we have a muscarinic antagonist, so dua-dua negatif lah kan, tadi kan positif kan. Okay, so when we have a blocker that binds to M1, M3 or M5, this would prevent phospholipase C from being activated, and then with this will also prevent production of DAG and IP3. So yang tadi excitatory tu tiba-tiba jadi inhibitory lah. Okay. And whereas for GI receptors M2 and M4, so if you have a muscarinic antagonist binding to it, so it prevents, so yang tadi adenylyl cyclase inhibited kan, so this time around the adenylyl cyclase will not be inhibited. So what happens to the level of cyclic AMP? It actually will be slightly sort of increase lah. It will not go down macam yang muscarinic agonist ni. Okay, so in turns, yang daripada inhibitory with agonist, it will become excitatory for antagonist. Okay? Alright. So before I before I go further, this one sebenarnya I patut tunjuk semalam, tapi tak apalah, I tunjuk hari ni. Because you need to understand what happens at the M2 receptor in the heart for you to understand what would blockade of M2 receptor dekat heart would do, because that is the clinical use of atropine. Okay, so let's have a look at the...
This diagram shows the M2 muscarinic receptor family and how that works in a little bit more detail. So the muscarinic receptors are coupled to G proteins, which are on the inside of the cell. And here we're showing it in a little bit more detail. Recall that these are present on the heart. So the muscarinic M2 receptors are coupled to inhibitory G proteins, or G sub I. And activation of those G proteins actually inhibits cyclic AMP and potassium flow out of the cell. Actually, it increases potassium flow outside of the cell. And this increased potassium outflow causes the cell to become much less excitable.
Okay, so as simple as that lah. So that is the reason why when we block, I draw this. Okay, so that's why when we block this, for example with atropine, Okay, so we block the M2 receptor from we block the ACH from binding to M2 receptor with atropine. So what will happen is that there will not be any increase in potassium outflow. Okay, so so that means that the charge ni dia akan jadi depolarized lah. So this one will be depolarized. So depolarization, bila depolarization, that means apa? Siapa cakap something tadi? Okay. Ya Allah, tulisan depolarize. Sorry lah, dah ke bawah dah. Depolarization. Okay. Okay, so when depolarization occur, that means your heart will beat faster. Okay, so that's the reason why we can give atropine to treat conditions like bradycardia. Bradycardia ni slow heart rate lah. Okay.
This diagram.
Dah. Okay. Alright. Alright. Okay. So let's look further in the types of muscarinic antagonists that we have. So we have the natural alkaloids such as atropine. So this would be the bulk of my lecture today. And other natural alkaloids such as hyoscine, or the other name for it is copolamine. And we also have the semi-synthetic derivatives or the synthetic congeners. This includes ipratropium bromide, tropicamide, and pyrazine. Okay. All right. So I'm going to talk further about atropine. So atropine is a type of alkaloid that comes from a plant. So the plant is called Atropa belladonna. Okay, so that is basically the italic names lah. Or we also call it as directly nightshade. So that's the first plant. If you remember the plant that I put in front of the front page of my lecture, so that is Atropa belladonna. Although the name is quite nice for you to consider putting as maybe consider to put as your daughter's name lah. Okay, so originally, so during the Renaissance era, if you remember, Renaissance era is like, you know, the French Revolution and whatnot. At that time, so the juice of the berries, so yang black one ni, this one, okay. So the juice of the berries, they actually crush the berries, and then they use the juice of the berries to dilate the pupils. And because at that time, it was considered as having dilated pupils to be pretty. Okay. So basically for cosmetic purpose. So at that, nampak tak keluar ni. Okay. So at that stage, dilated pupil is considered to be beautiful lah. Okay. So what are their mechanism of actions? Okay. So atropine is a non-specific antagonist. So what does that mean? So it blocks or it binds to all type of muscarinic receptors. So tak kisahlah if it's M1, M2, M3, M4, M5, it can bind to any of them because it's a non-specific antagonist. Kalau it's selective, then it can select which of the muscarinic antagonists that it wants to bind to. Okay. It has reversible antagonism. So means that if you increase if you remember your GM2, so pharmacodynamics, so reversible antagonism means that if you increase the agonist, you will be able to reverse the blockade. Okay. So what it does, of course lah, tadilah sama je, I cakap benda yang sama berulang-ulang. Okay. So it prevents acetylcholine from binding and activating the muscarinic receptor. Okay. Alright, so what are the important pharmacokinetics of atropine? So it's actually quite well absorbed orally and topically. Tapi kita tak adalah bagi all the time lah. Atropine ni bukan something that we give, you know, sesuka hati. Okay. So it is widely distributed, so it can cross blood-brain barrier which means that if you get a poisoning, you will also get the muscarinic receptors in the brain to be blocked. Okay, so that is the reason why you have to know why it can, what is the reason or the significance of why it can cross blood-brain barrier and why I put it in red lah. Okay, so if in regards to metabolism and excretion, so it's quite a rapidly excreted drugs with half-life only about 2 hours, and about 50% of them are excreted unchanged. However, they usually have a prolonged effect in the eyes. So in the eyes, they would have effect of about 72 hours or more. Okay, so we're going to look at the organ system effect. So this one, you can take your own time to have a look at it later. So pending on the dose, so basically the dose that we usually use is about 1 milligram. We don't really use below than 1 milligram lah. You can maybe doses like for topical eye drop, that one of course lah, smaller amount. But for IV, IM, or even oral, you use at least 1 milligram of dosage. Okay, so what would it do to the heart? It causes tachycardia. Okay, to the GIT system, so you can get dry mouth, thirst. To the eyes, you can get pupil dilation or mydriasis. Of course, the higher the doses are, you get more significant adverse drug reactions. Okay, so of course more than 10 milligram, that's basically very very overdose. So you can get severe tachycardia. You get a rapid pulse but weak. So dia punya volume tu you tak rasa macam kuat sangat lah. Okay, and then the patient may complain a very severe blood vision. The patient can starts to get flushed skin, hot and dry, ataxia, restlessness, excitement, and hallucination. So those are all due to the effect of ataxia, restlessness, hallucination, delirium, and coma. These are all because of the effects of atropine in the CNS. Kan tadi dia boleh cross blood-brain barrier kan? Okay. Okay. So mechanism of CVS effect. So at therapeutic dose about 1 to 2 milligram, the patient can get tachycardia, as well as these are due to blockade of vagal innervation at the M2 receptors dekat heart. So this will include the sinoatrial node and the AV nodes at the heart. And also it can cause vasodilation as well. Okay, so in the eye, if you remember whatever that I said in the eye yesterday, totally opposite will occur. Okay, so for example, yesterday we have contraction of iris sphincter muscle which causes miosis. So when you give a muscarinic blocker, you will get relaxation of the iris sphincter muscle or pupillary constrictor muscle, which will lead to mydriasis. So you get a dilated pupil. So yesterday, if you remember, we get ciliary muscle contraction or cyclospasm. Okay, so now we get ciliary muscle relaxation. So we also call it as cycloplegia. Plegia means weak. If you remember hemiplegia, okay, so cycloplegia just means weak ciliary muscle. Okay, so which leads to weakened contraction of ciliary muscle. And the if you remember yesterday, if we have cyclospasm, the patient will get a fixed near vision. Okay, so now if you have a cycloplegia, you tak ada dah lah fixed near vision tu, but you are not able to accommodate. Tak boleh nak tengok dah near vision tu. Okay, so you got affected, near vision would be affected. Okay, so you're not able to accommodate your vision. And if you remember yesterday, cyclospasm would pull the scleral spur and open up the trabecular meshwork, which leads to increase in aqueous humor outflow and reduce the intraocular pressure. So this time around, you don't have that pulling and you don't have the opening of the trabecular meshwork. So that would lead to increase in intraocular pressure. Okay? So terbalik je. You terbalikkan apa-apa saja yang semalam yang bagi tahu untuk cholinergic agonist tu, then you will get the effect of atropine. Okay. So yesterday we get with stimulants we get lacrimation. So with blockers you will get dry eyes. Okay. So inilah konon-konon lah tropabeladon ni kalau korang tiba-tiba terjumpa and you guys think that you wanted to dilate your eyes to make it more beautiful and so on. Okay, tumbuk-tumbuk bubuh dalam eye drop kan. Okay lah, although that is so not hygienic at all. Okay, so what it does, this is in the eye lah. So in the eye, the receptors, the muscarinic receptors are M3. Okay, so once the atropine goes, it causes mydriasis. So you get dilated pupils, which is due to the relaxation of the iris sphincter muscle. You also get cycloplegia, so you get increased intraocular pressure here. Okay. And then you will also, the cycloplegia will also cause you to lose your accommodation. Okay, so with regards to CNS effects, for example, what muscarinic blockers can do is it can actually reduce tremor in Parkinson's disease. So in Parkinsonism, I'm not sure whether you have seen one. So you can, after the lecture, you can go and find out a little bit about Parkinson's disease. If you are, I'm not sure whether you know him or not. So if you know Michael J. Fox, so the boy that was an actor, oh no, he is still currently an actor. Not a boy anymore, he's about, I think 50 or 60s now. So he has a young Parkinson's disease. So what happens in Parkinson's disease is that usually patients will get tremors, tremor, some problem with movements and so on. So it is thought that in Parkinson's disease, there is imbalance between dopamine and acetylcholine or cholinergic excess lah kita panggil. Okay. So what happens is that one of the ways to reduce this tremor is by we suppress or we reduce the cholinergic excess. Okay. And the other spectrum is we increase the dopamine lah, which is you're going to learn that in your CNS module, which is later in year 2. Okay. So it is also useful to correct vestibular disturbances. To treat or prevent motion sickness. So these are all due to the presence of muscarinic receptors in your vestibular nuclei yang dekat dalam telinga yang control our balance. Okay. When it goes to the brain, it can also cause sedation because it blocks the muscarinic receptors that is in the CNS. Okay. So other systemic effects include the ones in the lungs. So it can produce bronchodilation. So terbalik kan daripada yesterday. So yesterday muscarinic agonist can cause bronchospasm. So muscarinic antagonist causes bronchodilation. It can also reduce bronchial secretion because when it blocks, it reduces glands production of secretion. So in the for the urinary system, it slows down voiding or passing urine tu dia slow lah, boleh slow. And also it causes relaxation of the smooth muscle in the ureter and also bladder wall. Okay, so again, I have said this so many times. There are no drugs without any adverse drug reactions. So there are atropines adverse drug reactions include, so if certain patients can develop this, so they can get restlessness, which can lead to irritation, can lead to disorientation, tak tahu dekat mana, duduk dalam hospital tapi duduk cakap dia duduk kat rumah. Okay, so those are disorientation. In the eyes, they can get blurred vision, they can have increased intraocular pressure. So in terms of let's say if the patient has past medical history of glaucoma, you want to be careful if you want to give atropine to that patient. So obviously it cannot be used for long term lah. Okay, so cardiovascular system, of course, when a drug can cause tachycardia, it can also cause arrhythmias. It also causes cutaneous vasodilation as well. Okay, so in GUT or genitourinary tract, it can cause urinary retention, especially if you have a patient with enlarged prostate. So this would be male lah, male je yang ada prostate kan, perempuan tak ada prostate ni. Okay. In the skin, it inhibits sweating. So if you might want to relate why inhibition of sweating would lead to vasodilation lah, because these two are interrelated. In GIT, of course, because reduced secretion tadi, you reduce salivation, you get dry mouth. On top of that, when it can also lead to reduced peristalsis. Reduced peristalsis ni kalau dos atropine ni terlalu besar lah. Okay, so this is mostly going to be an overdose rather than the therapeutic dose. Okay, so what happens in atropine poisoning? So atropine poisoning or any other overdose with drugs that have anticholinergic properties. Okay. Okay, so not only atropine lah. So poisoning yang akan nampak dia punya signs and symptoms like atropine poisoning will include these other drugs. So these are some of the drugs that have anticholinergic properties. So if you take overdose of this drug, not only you will get side effects of that particular drug because it has anticholinergic effect, you will also get the anticholinergic toxic effects as well. Okay, so amitriptyline is a drug that we use in depression. It also has anticholinergic effects. Clozapine is a drug that we use in psychosis or schizophrenia. Antihistamine, these are your usual, ubat yang selalu doktor akan bagi if you have selesema or whatnot. And if you take too much of it, although it has other antagonistic effect at other receptors, it also has anticholinergic properties. And then for these are the drugs that we need to use in caution because it has anticholinergic properties, such as let's say if you want to treat motion sickness in children, of course not atropine lah, things like scopolamine, which is quite useful in treating motion sickness, but of course you cannot give too much high dose to children. For the other one would be diarrhea. So usually diarrhea in children, especially in children lah, we're talking because diphenoxylate and atropine is quite common for us to give for adult, but for children, you can use with caution. Most likely pediatrician would use it, not you as a houseman lah. Okay, so this would be the combination of diphenoxylate and atropine. So diphenoxylate is actually a morphine or opioid receptor agonist. Okay, so let's have a look at atropine poisoning. So these are the video that I showed yesterday.
So in this video, we're going to look at anticholinergic and cholinergic, the toxidrome, so toxicity. So let's begin by looking at anticholinergic toxidrome. A in anticholinergic, you can remember it as A from Alice in Wonderland. So here I'm drawing Alice from Wonderland, which features the Mad Hatter, the bunny ears and the hat. And Alice is out at a sunny place. Now this can help you remember the signs and symptoms of anticholinergic toxicity. And there's sort of a rhyme that helps you remember. Red as a beet, which is flushed. Dry as a bone, anhidrosis. Hot as a hare, antihydrotic hyperthermia. Mad as a hatter, delirium and hallucinations. full as a flask. This is urinary retention. And other signs and symptoms include tachycardia and decreased or no bowel sounds. Causes of anticholinergic toxicity is the use of some medications, for example, overdose of medications such as antihistamines, tricyclic antidepressants, and sleep aid medications. Now, so that was anticholinergic toxidrome. Let's look.
Okay, so cholinergic toxidrome kita dah belajar kan semalam kan? Okay, so that is anticholinergic toxidrome. Okay, tadilah samalah juga. So blind as a bat because of the obliterated iris, you can't really see. Dilated pupil, so you get a very, mydriasis. Mad hatter kan dia macam bengong sikit kan, okay. So confused, hallucination, delirium, okay. Alright, dry as bone, so you get dry mouth. The other thing then you get is urinary retention. You get shaking. Tadi kan I cakap. So you get tremors lah basically, okay. Tachycardia because of your heart, the effect of anticholinergic in the CVS. Red as beet. If you remember, beetroot kan very red kan, okay. So that just shows the flushed skin. Hot as a desert, so you get hyperthermia, okay. And then of course the absent bowel sound, the urinary retention and so on. Of course, the other things that you can remember it by, you can't see, can't pee, can't see, can't spit, can't shit, okay. So that's can't pee is urinary retention, cannot see is due to the obliterated iris, so the problem with the iris, and then mydriasis as well, of course. Cannot speak because of dehydration, so basically that's your mouth is as dry. Can't shit is because of the bowel movement is slow, so of course you cannot go to the toilet lah. Okay, so of course in poisoning you need to treat, okay. So what do we do to treat atropine poisoning? So tadi I cakap kan, so atropine is a reversible antagonism. So what they want to do to reverse the antagonistic effect tadi, okay. Okay, so first things first, macam biasa, you always have to remember ABCDE. So airway, breathing, circulation, drugs. I tak ingat dah E apa benda. Okay, so kena tengok semua tu lah. Whether you need to give oxygen, dry tu kan, dry, hypothermia, what do you need to do? You need to reduce the temperature. You need to give IV fluid because of the dryness and so on and so forth. Of course, you need to stop whatever treatment that is causing the patient to have atropine poisoning or anticholinergic poisoning. Okay, if you know that the patient may be overdosed, for example, you can limit the intestinal absorption. So I tunjuk kat sini dulu, okay. So limit intestinal absorption, what you can do? So you can usually do, this is the things that we do. For example, kita panggil gastric lavage. So katakanlah kalau patient tu baru je telan ubat tu berbiji-biji, like in the past, maybe 1 or 2 hours. So most likely the content is still in the stomach. So what you can do is that masukkan tube kat hidung, masukkan dalam perut lah, of course. You masuk air, tarik, masuk air, tarik. So basically you're trying to prevent further absorption of the drug. Okay. Alright. So we can also use something. So cara nak overcome the reversibility is to increase agonist kan. So how do we increase agonist? We don't really give acetylcholine directly. So what we do is we give anticholinesterase. So what anticholinesterase would do is it will inhibit acetylcholinesterase enzyme. So that would lead to increase in the level of ACH. Okay. When you have increase in level of ACH, which is the agonist to the muscarinic receptors, it will try to compete with atropine kan, okay, for the position on the muscarinic receptors. Tadi when I said the patient can hallucinate, disorientate and so on, so you have to remember when a patient have macam berterabur, you know, nak pergi situ, nak pergi sini, buat kacau satu walk, so you have to give some form of sedation to them lah. So you can give drugs such as benzodiazepine for sedation. Okay, when can we not use atropine? So contraindication of atropine. Alright, yeah, okay. Okay, so contraindication of atropine is when a patient has glaucoma. So we all know glaucoma usually have high intraocular pressure. So if you give atropine, that would make the high intraocular pressure worse. So that's the reason why we don't use atropine much in glaucoma patient. Okay, in patients with prostatic hyperplasia or enlarged prostate, or inilah hyperplasia / enlargement, or in patient that have prostatic urinary tract obstruction. Okay, so kalau dia ada sesuatu yang block, you don't want to give atropine because that can lead to urinary retention. Okay, GI ileus ni is the inability for your gastrointestinal tract to move. So basically yang tadi lah, you can't shit tadi tu kan, okay? So in GI ileus, patient tu dah lah tak boleh bergerak dia punya usus tu, dia tak boleh nak pergi berak apa semua. So you pergi bagi pula atropine that can lead to a further worsening GI ileus. So in GI ileus, you cannot give atropine as well. Okay, so the other therapeutic uses or clinical uses of atropine. Yesterday, if you remember, when we have muscarine poisoning or cholinergic poisoning, this is especially the muscarinic receptor poisoning lah. So you can give atropine to prevent the further effect of muscarine activation. Okay. So it's quite common, bukanlah kata rural areas pun, kalau orang yang tak tahu that mushroom is poisonous and they pick practically every single mushroom that they found on their en route, so those are the reasons why muscarine poisoning or mushroom poisoning can happen. Okay, overdose of an anticholinesterase drug. So if you take too much of drug that inhibit the acetylcholinesterase, you have a very high level of ACH, and of course you get cholinergic activation. Okay, so usually overdose of anticholinesterase drug can happen in patients with myasthenia gravis. You will learn this with Dr. Huzaimi in anticholinesterase drug, so I'm not going to talk too much about it today. So you can have a look at it first before your lecture. We can also use atropine to counter the effect on muscarinic receptors due to organophosphate poisoning. So usually this one yang minum racun lalang, minum I don't know lah insecticides and so on lah. Okay. Alright. So in cholinergic poisoning yang tadi lah yang ni. Cholinergic poisoning. I'm not talking about atropine poisoning because we're talking about the use of atropine here. Okay, so the two approaches for cholinergic poisoning, the ones that I said yesterday, was one is you want to block the muscarinic receptor. So we give atropine, or what we can do is by regenerating the cholinesterase enzyme. So we can use pralidoxime to do that. Okay. So these are some of the therapeutic uses of muscarinic blockers. So some of them lah. So atropine we can usually use for bradycardia. So slow heart rate, you can give atropine. Tropicamide, if you want, for example, you ada nak buat surgery dekat mata that you need the pupil to be dilated. So this is usually for laser lah, laser treatment kan, nak laser the back of the eye tu kan. Okay. Scopolamine, so we usually use it for treatment of motion sickness or prevention of motion sickness. Yang selalu naik dalam kereta, tiba-tiba rasa muntah, loya, whatever tu. So you can take scopolamine for that. Ipratropium can cause bronchodilation. So it is useful in patients with asthma or COPD or chronic obstructive pulmonary disorders. So the ones with a restricted or bronchospasm tu, you boleh bagi ipratropium to cause bronchodilation. We can also use muscarinic blockers in patients with overactive bladder. Maksudnya dia sikit dah kencing, sikit dah kencing, sikit terkencing. Okay? Or in patients with enuresis, which is bedwetting. So usually kan ada patient, ada budak even umur belas-belas pun still bedwetting. So these are the ones that you need to treat them. Okay. That's all. Thank you. If you have any question, I would have some time to attend to them. So hari ni pendek je because kebanyakannya dah